This is session 7, research talks. I'm Adam Katz from the University of Florida. This is Steve Kovac from UPenn. And we will move right along here. So our first talk is ICG Fluorescence with lymphoscintigraphy for sentinel node biopsy in head and neck cutaneous melanoma, a reproducible, reliable means to improve false negative rates, presented by Rebecca Nackstedt. Other authors are Rafael Cuoto and Brian Gassman.
Thank you for the introduction. These are our disclosures. For head and neck melanoma, the sentinel lymph node biopsy is the best prognostic indicator. However, reviewing the literature yields a sentinel biopsy positivity rate between 7 and 30%. This indicates that perhaps we are not selecting the correct sentinel node. Head and neck melanoma also has a high false negative rate as compared to other sites of the body. This is due to many reasons. From an anatomical standpoint, there are over 350 lymph nodes in the head and neck. Lymph node drainage can be to multiple levels and bilateral. And also, the lymphatic drainage has shown to be discordant in up to 80% of cases. From an imaging standpoint, the proximity of the primary lesion to the nodal basin can mask the gamma signal. Head and neck melanoma has a decreased prognosis as compared to other sites of the body, and it has been proposed that it is likely due to this high false negative rate. Somewhat confounding melanoma discussions is the fact that commonly used terms do not have agreed upon definitions. This is how we and the majority of the literature define these terms. Two important terms are the false negative rate and the adjusted false negative rate. The difference between these terms is that a false negative rate is a nodal recurrence with or without a local or in-transit recurrence, versus an adjusted false negative rate is a nodal recurrence without any local or in-transit recurrence. Using indocyanine green is an off-label approach that has shown utility in identifying sentinel nodes in gastric, breast, and gynecologic cancers. It has also been recently utilized in melanoma. However, there's little data thus far on head and neck melanoma. Some of its advantages: it has a decreased risk of anaphylaxis as compared to dye. It allows for transcutaneous visualization, does not require radiation, and does not tattoo the skin. However, it does require an expensive machine. It does not allow for direct visualization, as you must look at a monitor as opposed to looking at the patient, and because of this, there's somewhat of a learning curve associated with its use. Prior results from our institution compared two cohorts of patients with primary melanoma who underwent a sentinel node biopsy with either dye or radioisotope, or ICG and radioisotope. This study yielded an ICG node localization rate of 98%, which was higher than dye. Subjectively, it seemed that when we were using the ICG, we were able to reduce the node sample volume. Unpublished data from our institution looked at the first 100 melanoma patients who had a negative sentinel node biopsy that was identified with ICG and radioisotope. With a mean follow-up of 33 months, we achieved a false negative rate of 7.4% and an adjusted false negative rate of 3.7%. This can be compared to the Sunbelt Melanoma trial, the largest prospective study of melanoma patients, where they had a false negative rate of 10.8%. In this study, 6.8% of their patients were head and neck patients. In our study, 25% were head and neck patients. And as said before, this is a cohort of patients associated with a high false negative rate. Reviewing the literature for head and neck melanoma sentinel node identification means yields 30 articles using some combination of lymphoscintigraphy, gamma probe, and dye. 9 of these articles are prospective, and the sample sizes range from 20 to 365 patients. Mean follow-up is between 7 and 62 months. When we calculated the false negative rate for all of these studies, it was between 0 and 50% with a weighted average of 22.4. The majority of these studies did not mention the presence of local or in-transit recurrences, making the differentiation between false negative rate and adjusted false negative rate impossible. Our study hypothesis was that the addition of ICG-based technologies to lymphoscintigraphy for sentinel node identification in head and neck melanoma would augment sentinel node identification and contribute to a lower false negative rate. This was a prospective study of patients with primary cutaneous melanoma of the head and neck who underwent a sentinel node biopsy with the senior author from 2012 to 2015. Outcome variables were the definitions previously introduced, as well as specificity and sensitivity. Predictive variables included Breslow thickness, mitotic rate, ulceration, and regression. We had 61 patients and 100% nodal identification. 10 patients had a positive node and 51 had a negative node. We had 1 nodal recurrence. Thus, we had 1 false negative patient, 50 true negative patients, and 10 true positive patients. The mean number of nodes sampled was very similar between the true positive, true negative, and false negative patients. The follow-up mean was 27.6 months for true negative patients and 17.6 months for the true positive patients. The false negative patient had 16.5 months of follow-up. The false negative patient was a 69-year-old male who had a left cheek superficial spreading PT3A melanoma. It had a high mitotic index without ulceration or regression. He had 3 nodes sampled, all of which were gamma and SPI positive. He recurred in his nodal basin 230 days after sentinel node biopsy without any evidence of intransient or local recurrence. Thus, for our study, we had a false negative incidence of 1.6%, a false negative rate and adjusted false negative rate of 9.1%, sensitivity of 91%, and specificity of 100%. Thus, with our means of identifying a sentinel node, we were able to achieve a false negative rate of 9.1%. Once again, comparing this to the Sunbelt Melanoma Trial's false negative rate of 10.8%, where they only had 6.8% head and neck patients, and our patients were all head and neck patients. Comparing to the literature, where the average false negative rate is 22.4%, we were significantly lower than this. Our true positive index was 16.4%. The average reported in the literature is 13.4%. Thus, this reassures us that we are likely selecting the correct sentinel nodes. This was a single institution study, and the same personnel did not necessarily perform the nuclear medicine studies or the pathologic analysis. As we only had 1 false negative patient, there was no intragroup analysis possible. Our follow-up was longer than 2 years, which is the average time in which head and neck melanomas recur. However, as this is a prospective study, we will continue to follow these patients for longer-term follow-up. In conclusion, this is the largest cohort of patients with head and neck melanoma undergoing a sentinel node biopsy with radioactive and ICG-based identification. ICG-based technology is a novel approach to augment sentinel node biopsy, and we have shown that it is reliable, reproducible, and produces a low false negative rate. Thank you.
The discussant for this paper is Dr. Miller.
Well, let me congratulate the authors. Let me congratulate you, Dr. Naxted, for a wonderful presentation, for a very nice study. Donald Morton introduced doing this almost 30 years ago, and it's really transformed how we take care of many tumors now. But of course, its value is dependent on the accuracy. The questions I have 4 questions for you. First question is, why do you think that your lymphocytography with ICG as a dye is more accurate than lymphocytography with other dyes, like the blue dyes that are commonly used? The second question is, in your paper, you don't really tell us where the location of the melanomas were on the head and neck. And as you know, some locations have a more predictable drainage, like over the parotid, than other locations. So it might be helpful to know that. Your conclusion about false negatives was kind of an indirect assessment because you didn't actually biopsy the nodes. Is 2 years enough time to be sure that you don't have other false negatives like that? And finally, are there any technical points about doing this, or after your presentation today, can any one of us go out and start doing this and expect the same results that you guys show?
Thank you, Dr. Miller. To answer your first question about why I think the ICG is more accurate than the dye, the first study that we did, our ICG localization rate was 98% and dye was 79.4%. I think this probably has something to do with the ease at which you can inject ICG. When you inject the blue dye, it has to be very superficial, otherwise you can get dermal spread. Versus the ICG, most of the time it's the resident that's doing the injection. And so far we've had very good success with it always going to the node and always having a fluorescent signal. Your second question was?
Second question was about location of the primary tumor on the head and neck.
Right. Yeah, that's a very good point. In fact, scalp within head and neck melanoma has shown to have even a higher false negative rate as compared to all other head and neck sites. I do have that data calculated. I don't have it with me, but we did have a large proportion of patients that had a scalp lesion.
Okay. And then enough time for an indirect
Right.
assessment.
So the literature says that the median time to recurrence for head and neck melanoma is 20.1 months, and ours was beyond that. But I agree, this is something that we want to follow further, and as this is a prospective study, we continue to monitor these patients as part of our comprehensive melanoma program. So we do actively follow these patients for a long time.
So can I go out tomorrow and do this and expect the same results?
Your last question. Yeah, I think the only difficulty in using it is that similar to laparoscopic surgery, you're not looking at the patient necessarily, you're looking at a monitor. So just, being cognizant of that, remembering where you are anatomically, but the results are impressive intraoperatively. The fluorescence is very bright, the nodes are easy to identify, and then even once you remove it from the body, you can examine it on the back table, make sure the node that you took was indeed fluorescence, and then you can shine the camera into the nodal basin and make sure you didn't leave any obvious fluorescent node behind.
Thank you.
I think we have time for one more question.
Okay. Rogério Neves, Penn State University. I want to congratulate you as well for this great paper. I have some comments and a question. Yeah, we have been using that as well, and I think in the head and neck is the best utilization for this method, mostly because lymph nodes are so small and sometimes close to the area that we're going to resect. So we have a lot of background from the technician. So when you have and you can see, it makes it a lot easier to remove the lymph nodes. So I think it's really, really useful. My point is, you have a false negative. When you have false negative, and you are just here supposing that the false negative rate is just based on your surgery, but false negative rate is based on the good lymphoscintigraphy and also pathology. It's not only your technique. So I think you should think about it on those numbers. Also in head and neck literature, for a long time, they didn't even suppose that we were able to do sentinel node because the nodes were so small, so close, and so close to structures that were high risk, like nerves and other structures. And now we do it. So if you just go for historical, the false negative rate was much more because the surgeon was not willing to go to the node than we go right now. So this is another point that we have to take in consideration. I would like also to know from you what type of melanoma, because you just put all the melanomas, but if you have a lot of thin melanomas or more superficial spreading in that area, your recurrence rate will be a lot later, so we need a longer follow-up. If you have nodular melanomas, you may expect recurrence rates a lot earlier. So it is important for you to create the subsets of melanomas, otherwise this data may not be correct. So maybe with the subsets of melanoma in the high risk or not, if they are deep Breslow or high mitotic rate or something else, may change this data that you have. And finally, my question is, based on your data, do you think that we are ready to replace the other methods and use only ICG? Because the biggest problem is cost. So right now, you are just putting one extra cost on top because you are using lymphoscintigraphy plus the blue dye plus the ICG. So ICD will replace one of them. How can we do that? And because that is going to be a big change in what we do.
Yeah, I agree with all of your points, and that's a very good question. I know that at our institution, there's currently a clinical trial right now where they're looking at replacing using any radioactive injection and just using ICG with dye for breast cancer. So I think that this is a very reasonable option. I don't think we're ready for ICG to replace it. Right now, it seems as more as like confirming which node you're taking, allowing you to sample a smaller nodal basin. But it would be great if we could move in that direction that allows us a very surgery-specific nodal resection, because as you said, there's a lot of high-end real estate in that area that you don't want to damage.
What about the melanomas? Did you check the melanomas? Would you be able to see by thickness or by mitotic rate or ulceration if it just changed?
So for I'm not sure I understand the question. For our study, all patients had a Breslow thickness greater than 1 millimeter, so a sentinel node was warranted. The large proportion of patients were superficial spreading, and then the second most common was nodular. So, but I agree with a subset analysis would be great as we get more patients.
Excellent. I think we have to move on to the next talk. Thank you very much. Nice job.
Great, thank you very much. Our next talk will be Migraine Surgery Outcomes, an All or Nothing Phenomenon, presented by Lisa Gofrera from Massachusetts General Hospital.
Thank you very much. We have no disclosures. Migraine remains a mystery. Although over 35 articles get published on migraine every week, which adds up to around 1,600 articles published every year, there are over 320 million patients around the globe that continue to suffer from migraine. 35 million of these are in the United States. And 1/3 of these patients are refractory to any conservative treatment methods, including medications, injectables, and medical devices. When we look at traditional outcome studies for conservative treatment methods in migraine, we can see that outcomes are distributed as a bell curve in a normal distribution, which is characteristic for complex medical problems. However, we believe that in some patients, there may be a less complex etiology to why they're having migraine pain, such as an anatomic pathology, and there may be a more definitive surgical treatment. Dr. Gairon was the first to talk about a concept that nerves can be impinged between muscle, bone, fascia, and vessel, and can trigger migraine pain. He went on to describe different trigger sites, which you can see illustrated on this slide, and he also described techniques to release nerves from surrounding tissue. To keep it simple, we believe that nerve compression can trigger migraine pain, and that by decompressing nerves, we can alleviate migraine pain. A surprising finding in our prospective data further supports this theory. For this study, we included 45 patients in a prospective fashion and followed them at 3 and 12 months. 3 patients were lost to follow-up, so we evaluated a total of 42 patients at 12 months. We asked them to complete the Migraine Headache Index, which is the current gold standard to evaluate patients after migraine surgery currently. It is calculated by multiplying migraine headache frequency in days per month, migraine headache duration as a fraction of 24 hours, and migraine headache pain on a scale of 0 to 10. Traditionally, success after surgery is defined as over 50% improvement in migraine headache index, and failure is defined as under 50% improvement of migraine headache index. So when we look at our cohort of patients and look at the traditional cutoff for success and failure, we can see that 81% of our patients improved their migraine headache index by over 50% and were therefore deemed a success after surgery, whereas 19% of patients improved their migraine headache index under 50% and were therefore a failure. When we look at total migraine headache index score, in this group, on average, it fell from 122 to 32, which is a decrease of 74%. However, when we forget about the traditional cutoff for success and failure after surgery and look at different cutoffs, we can see that we have more binary outcomes than initially thought. Interestingly, 69% of our patients improved their migraine headache index over 80%, which is far beyond the traditional cutoff for success at 50%. Another 16% of patients improved their migraine headache index under 5%, which is far below the cutoff for failure at 50%. Only 14% of patients fell in the category between 5 and 80% improvement of migraine headache index. Now, when we only look at the people who did very well and their migraine headache index improved over 80%, average improvement was actually 97%, which is a complete home run, whereas the patients who had improvement under 5% had a mean improvement of 0%, which is a complete failure. So in 86% of cases, it's either all or nothing. It's either success or failure after surgery. So in conclusion, we see binary outcomes contrary to what we would expect in the treatment of a complex medical problem. Because these outcomes usually are distributed normally in a bell curve. And this is why we believe, and this supports a theory, that carefully selected patients have an anatomic problem to why they're having migraine pain. And when properly selected and properly treated surgically, they get better. Thanks.
Right. Thank you. Our discussant will be Dr. Ronald Ford.
Thank you for asking me to be a discussant. A couple of questions. I'd like to congratulate you first on your paper and your results. Interestingly, if you look internally on your results, they're very similar to what you've seen in most of the previous publications. About 85% of your patients got better. You do have this one small subgroup that is clearly a non-responder. Do you think, number one, that that's a misdiagnosis, that you're missing the trigger points? Is it could it be a accumulation of new trigger points? Or is there some problem within that group of patients that they have poor coping skills or whatever with their aspect? And then lastly, were there any trends that you saw in these patients that were non-responders? For example, were there trigger points in certain areas more seen in those patients?
Yeah.
Thank you.
Thank you. So to your first questions, why do we have non-responders? I think truly in the group that doesn't improve at all, we misdiagnose these patients. I think that their problem is not nerve compression, but we've misdiagnosed them. And I think we're getting better at selecting the right patients. But currently, there's no checklist, and you can just be like, okay, great, you've checked these points and you're a good candidate. But we're working towards that. And we're looking at these patients very closely to understand why they were misdiagnosed. I don't think it has anything to do with pain coping or any other patient factors. It's really just that the reason for their pain was not a nerve, but something else. To your second question, we are looking at trends towards why patients don't respond or do respond, and there's definitely certain things that we know are characteristic of patients who don't respond. But I think it's very early on, and I think I'd like to talk about that when we have more data.
Thank you. Any other
It
questions?
seems like you sort of just put a hodgepodge. I didn't see any sort of breakdown of which trigger points you released.
Mm-hmm.
Would you like to comment about that and what the different success rate is? Because at least anecdotally, from what I've seen, the septal trigger point tends to be one of the more black box areas where people either get well, worse, or something in between, as opposed to some of the the auriculotemporal site 5 trigger, which is pretty, like you said, binary. And then also, why do you think, if we're misdiagnosing, is it a misdiagnosis at the beginning, or is it the patient misdiagnosing it?
All right, so to your first question, when patients come to our office, we look at them overall. We try to identify all the trigger sites at once, and we try to operate on all the trigger sites at once if possible. So these are all comers that you can see here, and there's definitely a breakdown of which sites are more successful. Like the great occipital nerve is a classic site that usually responds best versus, like you said, the septal site. And there's definitely 14% of patients in our group that are somewhere in between, and those are the patients where we did not find all triggers and they improved somewhat but didn't respond fully, and they will need another surgery. And then your second question, I apologize, was, if the patient, if it's us misdiagnosing. I do think there are patients who are misleading us because they are desperate and they want surgery, and we have to be good at, or become good at identifying these patients also, but mostly I think we are misdiagnosing them.
Hi, Christian on Oklahoma City. Have you had long-term recurrence after a year of migraine, and how have you dealt with that?
So we think that after a year, most or our patients are stable. We don't yet have 5-year follow-up. Dr. Gairon has, and his patients have been stable, but we don't have that long-term follow-up yet.
Any other questions? Great. Thank you very much.
Thank you.
Thank you.
The last paper for this session is Development of a Virtual Surgical Planning Algorithm for Delayed Osseous Maxillomandibular Reconstruction, to be presented by Carrie Stern.
Thank you for giving me the opportunity to present. Over the last decade, there has been increasing use of virtual surgical planning in head and neck reconstruction. In most cases of complex head and neck reconstruction, one can use tumor specimen and normal references to base the reconstruction with or without virtual surgical planning. Traditionally, the specimen is used as a reference for bone length and combined with a sterile angulation template to guide reconstruction. However, in cases of delayed reconstruction, we don't have a specimen to model after using traditional means. The absence of anatomic landmarks and references make cases like this quite difficult. In cases of gross anatomic distortion, how do we restore anatomy and achieve an ideal outcome? Therefore, our aim was to develop an algorithm for delayed reconstruction of complex head and neck defects. Our hypothesis is that use of a reconstructive algorithm can facilitate virtual surgical planning of delayed head and neck defects. We performed a retrospective review of complex delayed maxillary or mandibular osseous reconstructions using virtual surgical plans. Procedures were performed at 2 major academic medical centers between 2009 and 2016. Virtual surgical planning was performed as part of the standard of care at both institutions at the discretion of the operating surgeon. 3D Systems assisted with the VSP plans and cutting guide fabrications. Defect location, size, anatomic distortion and possible constraints, and available imaging were all taken into consideration during the planning. Demographic and surgical characteristics were analyzed. 16 reconstructions met inclusion criteria with a mean follow-up of 21 months, and the majority of patients we looked at did have prior surgery. Mandibular defects were the most common, followed by maxillary, and 1 patient had a combined defect. All 3 maxillary reconstructions required 3 bone segments. Fibula was the most common donor site. 1 scapula was used. Indications for reconstruction included osteoradionecrosis, with severe anatomic distortion, followed by oncologic and trauma. These were our patients where we analyzed using normative data, which constituted about 25% of our patient population. 3 used fibula, and this was the 1 patient that required scapula as a donor site. Normative data takes advantage of the preserved angles between mandibular anatomic segments, so you can generate a virtual reference for reconstruction in green and then scale it according to the patient's size, as you can see in red. So if you look at the images on the right, the top green is the unscaled using normative data, whereas the bottom picture is the scaled based on the size of the actual patient, based on their native mandible. So this is a normative case example. What you can see is this is a displaced fracture. It's not clear exactly what the missing segments are. The green represents what the reconstruction would be using normative data. And again, what you can see here is that was what the initial displaced fracture looked like. But you can see that once you completed your resection, their anatomy was quite different and required a larger reconstruction than what was initially anticipated. Looking at the right side of the screen, you can see the preoperative panorex followed by the postoperative panorex following reconstruction, and in the lower left hand, you can see what the jigs were used for that particular case. Mirroring is another technique used, which uses the contralateral normal anatomy as a reference to guide reconstruction. This was used in approximately 31% of our cases. What you can see here is mirroring is less reliable for anterior defects. On the top, you can see what the patient's defect was, and yellow on the bottom side of the screen, using the mirroring technique. And comparing to the two prior techniques that were discussed, mirroring compared to normative, the red is what the reconstruction would be like using normative data, overlaid with yellow of what would be used using more patient-specific mirrored. This is a patient example. What you can see is a large defect extending anteriorly using mirroring. The bottom, you can see the jigs that were used, and again, the preoperative and postoperative panorex on the right. Patient-specific imaging is dependent on having available images of the prior patient's craniofacial skeleton prior to the reconstruction. So this would not be available in cases of trauma. It would usually only be available in patients that have needed reconstruction for delayed reconstruction for osteoid necrosis or oncologic reasons. Again, here you can see a patient-specific example. What you can see is the pre-operative image on the upper right hand, which was used to guide the reconstruction, the jig on the lower right. And this would not be possible if we did not have a prior image to model after. 4 patients required to take back to the operating room, with 1 required partial flap failure and 1 required a total flap failure. Other minor complications are as listed. 2 patients had oncologic recurrence out of the total 7. 5 patients required flap revision, and 2 ultimately underwent dental restoration. This is the algorithm that was created to help guide reconstruction in these complex cases. Patient-specific, we had a total of 7, and it once again requires pre-trauma or pre-resection CT scan, mirror imaging, difficult to do for anterior or midline defects, since the normal contralateral anatomy is not sufficient, and normative data requires rescaling dependent on the patient's size. So in conclusion, the proposed virtual surgical planning algorithm provides a systematic approach in cases of complex delayed reconstruction. Delayed reconstruction using VSP allows for precision that would not be possible using traditional means of shaping, given the absence of a specimen to guide reconstruction. Thank you.
Thank you. The discussant for this paper is Dr. Kovac.
Great. Thank you very much for that great paper. I think I'd like to congratulate the authors, because those of us who do head and neck reconstruction, these can be a very challenging patient population, and not only are there functional concerns with swallowing and speech, but aesthetic concerns as well, and they can be very hard cases to get right. I think with the rise of computer planning, it's really facilitated placement of the bone segments and the cuts during both harvest of the flap and preparation of the recipient sites. I think some of the things we struggle with for computer planning are, number one, the cost, and it can be cost prohibitive at times. So my first question is, do you use it for your primary reconstructions as well? And how do you justify the additional cost of the surgery? And the second is, you can make an incredible computer plan, but sometimes you can't really account for the compliance of the soft tissues and the soft tissue envelope that you can actually place it in. And I think sometimes our computer plans overestimates our ability to create a vascular construct. So do you think your relatively high take-back rate and revision rate is secondary to overreaching with the computer plans and being a little aggressive with what you can actually facilitate the construct to be? And then my third question is, our outcome measures for head and neck reconstruction are functional ones as well, so patients' ability to speak and swallow. Are your outcomes different in the arm of computer plan patients compared to patients that have traditional reconstruction without computer planning?
So I'm going to address your questions in reverse. So for the last question about outcomes, there's not enough data to know necessarily whether virtual surgical planning improves functional outcomes. There isn't good literature, given the complexity of these cases, to do a matched control study of using virtual surgical planning versus not is I would say, nearly impossible. So it's unclear, but what we do know is that using virtual surgical planning in an experienced surgeon who's been using it, who's sort of passed the learning curve, has decreased operative time, which is important for these complex cases. Your first question was regarding primary reconstructions. So again, based on the two senior authors' experience and standard of practice, most of the time virtual surgical planning is used for primary reconstruction. And again, it's sort of what their standard practice is at the two institutions and what the experience is based on the senior authors. The second question was related to depending too much on the actual plan and not taking into account other variables, including soft tissue envelope.
Yeah, a lot of these patients have been radiated, so they have a very non-compliant soft tissue envelope. So sometimes the limiting factor is actually the ability of the soft tissue to facilitate the reconstruction.
So obviously one of the benefits, or the greatest benefit, is on these virtual surgical plans is being able to create the bony construct based on the preoperative imaging. And the big unknown factor in all of these types of reconstruction, what happens to the soft tissue envelope? So yes, it's unknown how the soft tissue behaves, and to take that into account is quite difficult. And again, I don't think there's any good literature to say how much elasticity the skin has post-radiation, et cetera, which a lot of these patients have been radiated. And so potentially, yes, that is a reason why some of the patients required additional revisions or a second flap.
I have a couple of questions from Twitter. One, you sort of alluded to it, but we didn't get an actual thing. Can you give us an estimate of what the cost is for this, a ballpark, on case-by-case basis?
So depending on how many models are used, how many segments are used for the reconstruction, anywhere from $1,500 to $3,500, so an average of $2,000 per case.
And a kind of a corollary to that, the second question was, how accessible is this technology? How easy is it to get this?
I think it's quite accessible. It's very easy. You have whatever imaging CT that you have gets sent to 3D systems. At least that's what was being used in these two institutions. An engineer helps do the virtual surgical planning. Usually in about a 1-hour session, depending on the complexity of the case and the experience of the surgeon.
I think this question was first here.
Hi, Marco Ellis from Chicago. Just had a couple of questions. I find these to be very challenging cases myself. And what I'm curious about is, of the, I think, 14 or so cases, or 16 cases that you presented, during the operation, how many times did you actually have to discard your plan or to adjust it significantly? I know personally I can come up with some of the most elaborate schemes, but yet I find probably 1 out of 3 or 4 that it takes a quite significant change due to the bony anatomy, due to the pedicle not draping how you anticipate.
So I personally was not in all of these cases, but from my understanding, most of the time when the plan was kept in the operating room, potentially minor adjustments need to be made, but they're pretty spot on and really help guide the surgery, particularly with surgeons who are experienced using the technology.
And lastly, what I find most interesting is that we have transitioned to using this technology, which is quite impressive, and it, I think, speeds up operative time. But yet, if you look at long-term sort of outcomes, there's actually very little change. For example, I mean, looking at your data, it seems only 2 out of the 16 actually went on to get dental implants, which you would think is the largest sort of predictor of true success in doing this type of operation. Do you have any comments on that?
I'm not sure why all patients didn't go on. It could be based on the status of the patient, the indications for surgery, whether it was feasible or not, whether patients would benefit from it. So I'm not sure what the details were as far as why some of them didn't. It could also be based on follow-up and other procedures needed for those patients.
We have time for one last question.
Yes, I thank you very much for the talk. I think it was wonderful. At LSU, we've been using a virtual surgeon for planning for our primaries as well as our secondaries, and we find it very helpful. The question about the soft tissue compliance is most of these patients are going to have skin flaps along with the bone flaps. So you have to plan for the fact that the soft tissue may be a problem. And in some of our patients, we've done 2 free flaps. If there's enough sclerosis in the neck, we'll put an ALT in the neck and then the fibula and the skin paddle in the mouth. It does help the operative time, and whether patients go to dental implants has a multitude of issues, including funding. So I think it's a great paper. I'm glad you presented it. Thank you.
Thank you.
Before I let you go, one last Twitter question. Do you think with 3D printing becoming so ubiquitous that may replace sort of the two-tiered to doing that internally, I guess is the question.
Could it be done internally, potentially? So I think given the complexity of these cases, we're having an engineer sit and discuss the plan as far as how to best to do the reconstruction with experience. I don't think we'll be replaced by having local printers to be able to do this.
Thank you.